Hi, everyone. Thank you for sticking around today, and thank you for attending the Indigenous Health Research Saskatchewan Snapshots here. My name is Cheyanne Desnomie. I am the platform lead for the Indigenous Research Expertise and Engagement platform with the Saskatchewan Centre for Patient-Oriented Research, and I'm very honored to be moderating this panel today. We've got some really interesting presentations coming up. So just as a brief overview, this session showcases 4 different teams speaking on Indigenous health research that they're doing with communities across the province. And in addition to these 4 teams that were selected to present, we also have 4 e-posters on Indigenous health research that is available on our website, and we strongly encourage you to visit them. You're able to comment on them and reach out to each e-poster team as well. So just a few housekeeping notes before we begin. The chat box is also still being moderated by an IT specialist in attendance, and the session is being recorded as well. If you're having problems connecting to Zoom, please call 306-766-5140, and attendee mics will be off during the presentation, although you may keep your cameras on. Questions can be written in the chat box to be addressed at the end of the presentation, and hands can be raised to ask questions at the end of the presentation as well. And so when you are asking a question, please introduce yourself and where you're from, speak loudly and clearly, limit yourself to 1 question due to time constraints, and ensure that the question is related to the presentation. And following the end of showcase, all attendees will receive a survey, and we'll ask everyone to please take time to complete the evaluation. Now, before we begin, I also do want to just provide a brief land acknowledgement. So in the spirit of reciprocity and truth, I'd like to acknowledge that we are on Treaty 4 territory, which is where I am moderating from in Fort Qu'Appelle, Saskatchewan here. And this is the homeland of the Métis, in addition to various First Nation groups across Treaty 4 territory. I'd like to pay my respect to ancestors of this place and reaffirm our relationship with all nations and peoples of this land. So with that said, I would like to bring on our first presentation, which is called Service Provider Perspectives of Indigenous Patients' Cancer Care Needs. And our presenters are Jennifer Sedgwick from the Department of Community Health and Epidemiology and Anim Ali from the Department of Community Health and Epidemiology. And with that said, I will hand the mic over to them. Thank you.
There we go. I muted myself. Chris, can you please give me a thumbs up if you can see the presentation? You good? Okay. I'll make it full screen then. Make sure I can see everyone. All right. So thank you for the introduction, Cheyanne. I guess I won't go over the introductory slide and then just dive in. So this project was informed by some of the current health status of Indigenous peoples in Canada with respect to cancer. So in Canada, Indigenous versus non-Indigenous peoples have disproportionately higher cancer diagnosis rates, but also lower survival rates. And aside from the health outcomes, there's also differences in accessing care. So for example, some Indigenous groups have different medical coverage in comparison to non-Indigenous peoples. There's also geography that's more of a unique barrier, and also culturally relevant services, or a lack sometimes of culturally relevant services for accessing care or when in care. And so taken together, this informed the project Sagapakawin, which means budding or sprouting in Cree. And this is a multi-phase project that has the overarching aim of identifying Indigenous people's cancer support needs during diagnosis, treatment, and follow-up for the purpose of implementing evidence-based interventions. And so this is just to note specifically in Saskatchewan. So right here, bottom left, is our research advisory team, where there are 4 Indigenous patient partners, clinicians, academics, and policymakers. And so that's a picture of some of us there. Obviously not a current picture. Haven't gotten together in a long time. And the current study, this is just one of the phases of Saskatchewan, which is to conduct a needs assessment to identify the support needs of Indigenous peoples affected by cancer from the perspectives of service providers. And so for this study, we employed a qualitative methodology and used semi-structured group interviews we conducted 3 group interviews, one at the Saskatoon Cancer Centre, one at the Alan Blair Cancer Centre in Regina, and then the other at the COP Centre in Prince Albert, the Community Oncology Program of Saskatchewan. The participants were cancer service providers that ranged from chemotherapy and radiation nurses to social workers to practicum students. And then after our data were transcribed verbatim, Dr. Lee and I conducted a thematic analysis using Braun and Clark's approach. All right, and so these were our findings. We had 5 overarching themes of support needs and then sub-themes, 2 to 3 within each of those themes. I won't go into all of them for the sake of the presentation, but you can see all of them there. Instead, I'm just going to go through each theme and present a quote that kind of highlights the experiences that was shared by the service providers. So for this first theme, addressing travel-related needs, this was a key priority that came up in all of the group interviews. So here's a quote that exemplifies the barrier or some of the consequences of these travel-related issues. Quote, I did work for a Northern health organization where we would have people who would just choose not to get treatment because of the time that it would take away from their community. Obviously, choosing not to get treatment has severe consequences. And so another quote from a different participant to try and address this issue was, one thing that we find is they need more support in their home communities. And so more support, some of the examples that they had given were things like training some of the Northern healthcare facilities and things like line care so that participants aren't having to stay in, Saskatoon, Regina to get that type of care, but also with the expansion of COPs to communities beyond Prince Albert. For the theme logistical challenges, this was particularly with regards to kind of communication breakdowns with the NIHB. NIHB being the non-insured health benefits program, and this is specifically for First Nations or registered First Nations patients. This doesn't apply to Métis, just to know. So quote, my longest time on hold on the phone was 1 hour and 21 minutes waiting to get through to them. So that's formal resources being used inappropriately. Another example that's relevant is I'm getting told by NAHB, no, because they're close enough to the hospital that you shouldn't need a taxi. So then I'm fighting about that. So if we don't know the system, then our patients aren't getting the services needed. So there's a couple angles coming at this logistical challenge, essentially, that there's issues with communication, but also that service providers are having to do advocacy at the same time as providing this formal support. So there are some challenges that need to be addressed, particularly with regards to the NIHB. All right, the third theme was improvements to Indigenous specific supports. And so these are for improving existing supports to be utilized, I guess, in a more effective way. And the most common something that came up was regarding language interpretation. And so this is already an existing support, but I guess I'll just read this quote. We can't just have one Aboriginal person come in here and say, okay, well, I represent everybody in Saskatchewan. That's not going to happen. Language is one of our biggest barriers, and trying to rectify that would be a huge step in the right direction. And then this need is really exemplified with this quote. Even though we do have interpreters, I think having having enough or having more would be very beneficial. And so just to note, this isn't just more in quantity, this is also more with regards to Indigenous languages. So the need for Dene came up a couple of times, that there's no Dene speakers represented within the language interpreters, at least with the service providers in their environment. All right, so with regards to consistency in care, this was a theme that emerged particularly with regards to oncology appointments through telehealth. So telehealth, of course, is supposed to be a support that can address the geographical barriers. So this is something that cancer patients can have in their home communities. But here's a demonstration of where they're something that's a need. Here, I'll read this quote. They might go to telehealth in January and see their primary oncologist who they've always seen, and then they go in February, March, April, May, and see someone different. And it may be a different person every time, let alone just one person. So why this is an issue is exemplified with the bottom quote. I think that transition of primary care providers for a lot of people, especially people from the north, when you talk about trust issues, that is not good to have fill-in doctors come in. They don't have the same rapport. The stuff they talk about at one telehealth may never come up again. And so essentially this is an issue, because if they're not getting the information, all of the pertinent information that they need, they can't provide the most informed quality care. And then the last theme that emerged was cultural sensitivity in healthcare. So one participant notes, it needs to be more than just an Indigenous sensitivity training that usually is typical of a checkbox. They facilitate a conversation about it, but don't continue doing more initiatives. And so they stated that this was something that should be addressed, not just when in the profession, but also within education training. And the bottom quote reads, having a better understanding and respect for the holistic side of things too, to integrate them better, present all options, and make informed decisions. So the participants highlighted that they're not just having like a cultural sensitivity component, but also having information on, traditional healing methods, so that they can at least provide informed options for Indigenous cancer patients who might want to use different routes of care. So for the discussion, I just wanted to make some points that kind of contextualizes our study. So the discussions from the service providers were particularly focused on the needs of First Nations cancer patients. And while these needs might, also extend to Métis cancer patients, some of the things like those logistical challenges with regards to NAHB, that's going to be specific to First Nations cancer patients. And so just to highlight that from our findings. The second is that many of the barriers that were identified by the service providers were also identified from previous research with Indigenous populations. And a last thing to provide some of the context is that, of course, the needs that were identified from our study was specifically from service providers, which of course might be different. Those needs might be different for Indigenous cancer patients themselves. And so that is why a part of our a part of the other phases of Saskatchewan is to conduct interviews with Indigenous cancer patients. And so for the recommendations for policy and practice, they're essentially in three types of themes. So for Indigenous specific cancer support needs, Indigenous specific accommodations. For system related needs, communication between all levels of government support, formal supports in northern communities, and cultural safety training. And for existing Indigenous cancer support needs, culturally relevant supports such as elder support in all locations of cancer care, and more Indigenous language interpreters. All right, so I'd just like to acknowledge the other people on the research team for this project. Dr. Gary Groot, who's also the primary investigator on the Saskatchewan grant, Dr. Tracy Carr and Andrea Badea. And also like to acknowledge funding from SSHRC and SCPOR. And also just want to highlight that we are submitting this to the journal Ethnicity and Health, so fingers crossed. But we also sent a report of this to the Cancer Agency, I think back in June. So yeah, so any questions? Marcy, thank you everyone for listening to the presentation.
Thank you, Jennifer. Due to the time constraints, unfortunately, we're going to have to do the questions via the chat. And we will continue on with the next presentation at this time. So the next presentation is called Community-Based Dialysis in Saskatchewan First Nations, a grassroots approach to gaining insight and perspective from First Nations patients with chronic kidney disease. And our presenters are Dr. Lindsay Rochelle, who is first author, Dr. Barney Richardson, principal investigator, Dr. Michelle McCarran, the co-applicant, and Val Desjardins, a community member. Thank you. Go ahead.
Hello, good morning. Thank you very much for inviting us to speak today. We're going to be talking about community-based dialysis in Indigenous people. The flow of the presentation today is going to be a little bit about the background, a little bit about our study, a little bit about what we found, some suggestions in our work, and I think most importantly to have a real life experience of what it's like to live it on dialysis. Just a way of background, when we talk about dialysis, you either can have dialysis in hospital or you can have dialysis at home. And there's two ways of having dialysis at home, either through the belly or through the blood. So thank you very much. Through our research, we found, and I don't think this is a surprise to a lot of us, we generally found that there's very much a higher prevalence of renal failure and obviously diabetes in First Nations people, much younger at the age of diagnosis with much more severe disease. Unfortunately, Indigenous people die younger, and really significantly, they travel a lot further. Our research showed that the average travel time to see a nephrologist or dialysis for Indigenous people were 234 kilometers in Saskatchewan. You can just put that in perspective, thinking about doing that 3 times a week, what a significant burden that is to your life and your family. So what we did in our research is we went to communities and sharing circles, and we interviewed people in their communities, and we listened to them on what the barriers were for doing dialysis at home. Home dialysis, we know, have generally better outcomes. You live longer and you do better at home than the hospital traditional dialysis. And we wanted to understand why Indigenous people were not choosing the home dialysis as much as the hospital-based dialysis. The study was very collaborative. First of all, we went to our partners in FSIN, and we went to various tribal councils. We received ethics authority from the Indigenous Council, and we had collaboration from All Nations Healing Hospital as well. The project had 2 components to it, one quantitative and one qualitative. The qualitative component was to understand that the First Nations barriers for implementing home dialysis, to go out in the community and say, you know, why aren't you choosing this? What do you know about this? What are those barriers? And really listening to the stories from the people in the communities, the family members, the providers, and the patients themselves that are living this experience. I don't know if you can click off. There's a bunch of pictures on the right side. Hard to see the slides.
Oh, I think if you go.
So again, we had a research held in circles, sharing circles, and we had various people there. We had elders and we had people that practiced in a traditional manner. We had 67 participants, and then we did 4 really in-depth patient interviews as well. Sorry, it's not advancing now. Was it this one I hit? There we go. Okay. So what did we hear from our patients and our people in our communities? We heard again and again, there's just barriers, system, geographic, lots of different things. One of the things was just the infrastructure. We heard again and again about the lack of really good quality water in First Nations communities. And that has a significant barrier. Out of the two types of dialysis, one through the belly doesn't require water, but our other type of modality, what we call home hemodialysis, does require good water. So that was an issue. There's an issue around just having basic infrastructure, even electricity in the homes at times. And even when we're talking about the belly type of dialysis, which doesn't need the water, storage space, there's some equipment there. And sometimes the homes people were living in just didn't have enough space to do this type of dialysis. Again, what we were hearing from people is that as a program, we aren't communicating in a way that people feel like they have a good knowledge about chronic kidney disease, that they're equipped to make good decisions. And the other thing I think that we heard about is, sometimes it was called the moccasin telegraph. It kind of goes around the communities and, we heard this about somebody and this about somebody else. And having that information wasn't always necessarily accurate. It was fueling sometimes a lack of understanding about home dialysis, things like safety and efficiency. The other thing we really identified is what about, giving this more from a systems approach, more community-based, more focused for what we need. We deliver our kidney program in our traditional way. And what we heard from a lot of the participants is, this would be maybe an option for me, but, for instance, I live in my home and I have a 14-year-old granddaughter that can help me, but maybe our program has a barrier that somebody has to be 18 or we're not thinking so much outside the box. And people just sort of felt that maybe it would be overwhelming to do home dialysis in the home. Again, as far as the communities, different communities have different capacities, different opportunities, different resources, and some communities have more resources than others. And what was really felt with the participants is we would like to have somebody in our own community that is leading, is the mentor, is the go-to person in our community to support us with home dialysis. And your kidney program can be giving that knowledge and working with people in the community, but we would like to have somebody as a champion in our community to help with the people in the community with their choices and helping them to be more successful. Again, the system-based barriers we've been speaking about, and there was actually even some language barriers, particularly in the north on. And when we talk about language barriers, that's not necessarily just English alone, but the way we communicate in our health talk speak, it has to be in a way that people can actually understand what we're trying to convey. Sometimes that message just gets lost. What were some of the solutions? Well, some of them were, we could have things maybe closer to home in communities. For things, if there's not enough supply in the home, can we have a central supply place where we can drop things off in a health center, a community center, a school, a gym, anything? Lots of these communities had answers to their own problems or opportunities. We talked about having dedicated people in the communities just to champion and help support people in the community. We heard again about different ways to communicate. It would be really helpful, we heard from the participants, to have people maybe in more of an oral tradition to be talking and educating about home dialysis in a storytelling method and all those supports in the community. We had lots of conversations around the effects of living with chronic kidney disease. Obviously, it's a very devastating chronic kidney disease with the physical and the mental burden. And it's a lot of burden with the caregivers. And again, the burden of travel, 234 kilometers. It's almost impossible to live in a community like this and do blood dialysis because you spend half your life in a taxi. I'm going to mention lived experience, most important, and introduce Megan and Derek and their family, as they are going to tell us what it's actually like being on dialysis. And this is the way that we did this project. So I will introduce you to Megan Asana and her loving husband, Derek, and her family. And there you go.
Hi, I'm Megan. I've been living with dialysis or chronic kidney disease since 2016. I started dialysis. I already had my daughter, and it was hard at first going to hemo. And I live an hour away from Regina, so traveling back and forth did take a toll. I was always tired all the time, and I've had every option available for dialysis. I did have the hemo, I did the peritoneal dialysis, and I did the home hemodialysis. And in 2018, I got pregnant with my son. I was on peritoneal dialysis, and as soon as I found out that I was pregnant, I had to come off and go straight to the hospital and start hemo as soon as possible. It was a difficult pregnancy because a lot of doctors haven't seen my case before, and there was a lot of negative along with positive. And with the home hemodialysis, it helped us a lot because I wasn't able to do it at home because of the water situation, but I was able to do it at my local hospital in Fort Capel. My husband took the, how long? 6-week training to do all of that at the hospital. So I was on dialysis every day for 6 months for 6 hours to bring my son into this world. And it was hard because a lot of doctors telling me that I couldn't have babies anymore, or that I would have a stillborn if I went through with my pregnancy, or that I would miscarry. But I proved all of them wrong, and I had my son. He was born very early. He was born at 27 weeks. He weighed 1 pound 7 ounces, and I had him by emergency C-section. But it was like very, very well worth it. And I couldn't thank my husband enough for helping me through everything, through the time I needed to start dialysis, through all of my surgeries that I needed, and with my lines and going on PD. We learned a training for that. That was 2 weeks. And then the 6-week training for the home hemo was lots, but it was well worth it. I still go to hemo. I am slowly getting everything together to be a candidate for a transplant. And I just have a lot of appointments all the time, but my biggest support is my husband and my kids. They're always with me wherever I go. Well, since COVID, my kids stay home a lot, but they're always with me all the time. So we do go to a lot of doctor appointments, and with dialysis, I still go to my local dialysis center in Fort Capel. It's called Rising Bear. And I like to thank my nurses who take care of me, because without them, I wouldn't be alive without them doing my dialysis. And I do believe in my traditional ways very strongly. And Rick Fable, he gives us medicines to drink before and after dialysis. And I really enjoy that, because I do strongly believe in my culture and my ways, and I'm trying to get better for my family and for my kids so that I can live a longer life. And I know it's not easy. It's very hard. We have our ups and downs. We broke through a lot of barriers that were in our way, and I just want to continue to inspire people that yes, it is an ugly disease, but at the same time, I got my son out of it. And that it was just meant to be, I guess, for me to have a baby, because while on dialysis, I was on the peritoneal when I got pregnant twice. My first baby, I had a miscarriage, and then my second baby was him, and a successful pregnancy. And I'm very, very happy and thankful for all the positive things that Dr. Richardson and some of my nurses told me all the time, that like to keep on going and everything. And it made me fight harder, and it made me just want to prove people wrong, because there was doubtful doctors and doubtful nurses that told me not to have my baby, told me to abort my baby and not to go through my pregnancy, and just telling me a lot of all the negative things that can go wrong. But at the same time, just a few little words from Dr. Richardson or my nurses, all the positivity just kept me going. And I really, really love Dr. Richardson for that. She's like a motherly figure for me, and like a grandma to my kids. But I just want my story to get out there, because I know it's rare that dialysis patients have babies, and I had a baby while on dialysis. So, you want to say anything?
Okay. I'm kind of shy. Thank you.
Thank you.
Yeah,
so
thank you.
much. Thank you. So thank you so much. I don't know if we have time for questions.
Thank you to you and your team. Due to time constraint, we'll have to do questions once again in the chat, but thank you so much for your presentation and for sharing your story. It was very impactful. And with that said, we'll move on to the third presentation here, and it's called Engaging Urban Indigenous Older Adults with Technology Use to Respond to Health and Wellbeing Concerns and Needs. And our presenters are Dr. Carrie McIlduff, who is the principal investigator, and Mr. Victor Starr. So I will hand it on over to you. Thank you.
Thank you, Cheyanne. That's a hard act to follow. Cheyanne, can you let me know that you can see my screen?
Yes, you're good.
Okay. Okay, so just acknowledging that I am from the Morningstar Lodge, and I have a lot of mentorship and leadership from Indigenous peoples, but I am white. And I do want to acknowledge, I know that Cheyanne, you did the land acknowledgement at the beginning, but I do want to acknowledge the, in the way that I was trained in my home country, to acknowledge the leaders past, present, and future of the lands that we present from. I also want to acknowledge and say hi to my co-presenter, who's very brand new to the team, so I'm not going to put any pressure on him to present, Victor Starr, who is a member of the Star Blanket Cree Nation. Did you want to say hi, Victor?
Yeah, hello. Can you hear me?
Yes, hi. Thank you so much for making time to be here. We're excited to have you as part of the team. So feel free to jump in at any point. I know you have this and you're brand new to the team, but anytime you want.
Okay.
Okay, so I'm just going to go through a little bit of the basis around this research. I recognize that listening for the last little bit that we're not as far along in the research that the other presenters are, and I don't have any inspiring stories to tell you at the moment in regards to this research. So like I said, that's a bit of a hard act to follow, and thank you for sharing your story. Very brave and courageous, and wish you all the best. So the basis of the research that we're doing is with older Indigenous adults that have expressed that they've shied away from seeking health services due to fear of contracting COVID-19 as a population with two high vulnerabilities, both as older adults, but also as Indigenous peoples who have a lot of comorbid conditions. So many Indigenous older adults would like to learn and have expressed the want to learn more about technology and recognize the value of the technology in supporting healthy aging throughout their lives. However, the Morningstar Lodge has previously found in their other research that the accessibility and readiness were key factors in using the technology. So it will be different with our urban Indigenous peoples that we'll be working with from the Star Blanket Cree Nation, because there'll be access to an internet infrastructure. However, we do want to recognize that both the devices, which are expensive, as well as the internet infrastructure globally is unreliable and or not there. So there's also quite a bit of information within the Morningstar Lodge around cultural safety and cultural appropriateness, and we do want to make sure that that is a key space within which we work for our older Indigenous adults accessing technology, and things such as even FHQTC has Indigenous language apps that we're going to download onto tablets for the older Indigenous adults. And what a great way to spend some time in quarantine or isolation by learning new languages. Yeah, so increased access to technology can promote independent living, stimulate cognitive functioning for some of our older Indigenous adults that are already experiencing some symptoms of dementia or Alzheimer's. It may relieve caregiver stress, access to telehealth, increase overall well-being, and be used to share cultural resources such as Indigenous language apps. This research in particular aims to promote a healthy lifestyle by learning from older Indigenous adults about what they want from technology to support a healthy lifestyle and increasing access to and engagement of culturally safe technology solutions, particularly in the current climate of the pandemic. Perfect. So the beginning of this research has really started with my wanting to compare and contrast the ethical engagement module that my boss, Dr. Barassa, a Métis woman here in Saskatchewan, has created for Age Well, and the model of engaging communities collaboratively, which I created with the assistance of international Indigenous feedback when I was doing my PhD. And so I've been to countries such as Panama, Australia, New Zealand, Fiji, and I've been in communities in America and Canada as well. But I find it interesting that there's so much synergy around what's really needed to work well and have best practice methods within Indigenous communities. So the principles of ethical engagement for the ethical engagement module are cultural safety, community-based partnerships, which we'll talk about a little bit in a moment, communities as co-researchers instead of calling them participants. And this is really around the imbalance of power that a lot of language puts out there. And within research, if you call people researchers and then participants, there's automatically a imbalance of power there. And so our communities are definitely our co-researchers, and that's different in wording than a lot of researchers. And then using traditional knowledge to put forward research, the OCAP principles, reciprocal learning, knowledge translation. There is a lot of synergy in between, and I know it's going to be a little bit harder for you to read all of the cogs in the cogwheel per se. But the two that I wanted to draw attention to was the OCAP principles, which are being utilized a lot in ethics and throughout the nation. However, they're often brought into ethics applications at the end. So once the data is analyzed and we're doing the knowledge translation, then we talk about ownership, control, access, and possession. And I just want to challenge researchers, and I know this is not easy, but 100% worth it for ethical engagement and ethical research, is to bring in the OCAP principles at the beginning of the research, and to really have Indigenous communities leading that research. And I may be preaching to the choir, I'm not sure who's all here, but this is, yeah, really important. And the knowledge translation concern, I know that it is something that is definitely addressed again in ethics, and we try to do it as researchers. But a lot of the time when I would speak to communities throughout all of these countries that I've been in, that is the weakest point of research. And I'm not talking about just the presentations, I'm talking more about when Indigenous communities are part of the data analysis to make sure that the interpretation, particularly of qualitative data, is appropriate, as well as giving approval to do papers, publications, conferences of that knowledge once it's put together, not just assuming because we've got consent at the beginning that we're still okay to keep going with the knowledge translation in the way that we think is appropriate. And that really includes making sure that Indigenous communities and leaders are part of the authorship, part of the analysis, and then the presentations. Unfortunately, Victor, like I said, has just joined our team, so I don't want to put too much pressure on him to do presentations at the moment, but eventually he'll be leading some of this stuff. So, and then so I just want to talk very briefly about Community Research Assistant, just aware of time, and the Community Research Advisory Councils. So we've just hired, like I said, Victor on as a Community Research Assistant, and he is creating the Community Research Advisory Council, or the CRAC, in the Star Blanket Cree Nation. So oftentimes the CRA, or the Community Research Assistant, is the first point of contact for researchers, who then develops the CRA from the leading of the community, co-leads the research, and facilitates the relationships that need to be built to do ethical research. So the CRAC is composed of elders, knowledge keepers, healthcare professionals, and respected members of each community of the local governing body. So as an example, the Star Blanket Cree Nation, particularly for this project, has asked that their CRAC has local younger people, which I think is brilliant because of technology. A lot of the younger people know more about what technology has to offer for in general. So guidance from the CRAC members ensures research is relevant to the community and prevents the likelihood of colonial research practices such as helicopter research, which I won't go into due to time today, that are often designed to serve academic and corporate interests over Indigenous communities' interests. And so I think we really need to recognize and consider the history of research within communities, Indigenous communities globally, and the damage that has already been done, and that we need, in order to reconcile research for and with Indigenous communities, that the ethical research and ensuring that communities lead is just really important. So this is kind of the timeline of the project. We're looking at accessing healthcare services and health information. So right now we're developing the CRAC, having initial conversations with the CRAC around the approval for the research, the approval for the questions, the methodologies, and really seeking their guidance on what's going to be on the tablets to begin with. And then next we'll be working with co-researchers or participants in other research language that will just look at conversations with what would be ideal, because each individual will want or need something different on tablets to access healthcare services and information. Well, I'm going to go back a little bit to the CRAC and just say, kind of like in academia, we can't move anywhere without ethics approval. The CRAC, we can't do anything, or we shouldn't do anything in Indigenous communities without the guidance and approval of the CRAC and the CRA. Then next we'll be individually tailoring the tablet setup, and those tablets will be owned by the co-researchers at the end of the project. And the educational research, or the educational workshops, the only one that has been actually created so far is the first one, which some will need more than others. And that's really simply around how to use the tablet and all of the nuances of a new device for someone, and then how to use Zoom, because we're in the second wave of COVID. So we want to make sure that we're doing it the safest way possible, and hoping that we'll have some CRAC members that can help set up and teach Zoom in person, instead of adding a new body into someone's home or into their workspace. And then we'll be doing the evaluation. So that is it for me today. This is my contact details. And we don't have a works email for Victor yet, so I haven't put that on. And then the references, and I know that we're doing questions via chat. So go ahead, Cheyanne. Thank you. Victor, do you have anything to add before I pass it over?
No, that's good.
Okay, thanks.
Thank you so much for your presentation. Very impressive methodology that you're using. So I really appreciate that as an Indigenous researcher myself. So that said, we'll move on to our final presentation for this session. And it is titled Peer Health Advocacy Wellness Network, Commencing a Network of Peers Within Rural Indigenous Communities in Saskatchewan. And our presenters will be Tricia Campbell from the Peer Health Advocacy Wellness Network Coordinator, and Danita Wapuzian, who's a peer consultant. So go ahead and take it away. Thank you.
Hello, can you hear us?
You're good.
Okay. Hi, good morning. My name is Tricia Campbell. I'm a First Nations woman of Cree ancestry and the peer coordinator for the Peer Health Advocacy Wellness Network, FON for short.
Hello, Tansei. My name is Danita Wapuzian, and I have my spirit names is Lightning Rock Woman and Pulse for Women, and I am the peer consultant for FON. I'm also a person living with HIV since 2005. I have worked in the HIV world for the past 14 years. I'm a proud Cree and Saulteaux person residing in the city of Regina, Saskatchewan, and I come from Treaty 4.
We would like to acknowledge the land in which we live and work, provides us with country food and traditional medicines, and allows for maintaining healthy lifestyles and physical activity, all gifts from Mother Earth. We are presenting from the Treaty 4 territory, home to the Cree, Saulteaux, Dakota, Lakota, and Nakota, and the traditional homelands of the Métis Nation. We should also acknowledge and remember the ancestors that came before us, as we are here because of them. When we work together, we should listen to understand each other and be kind to one another. We do this work to benefit one another. Thank you to all our relations.
First Nations partner communities identified a need for peer health advocacy. First Nations partners developed peer supports to address community health priorities and to promote access to culturally responsive approaches to well-being.
The Virtual Community Care Clinic, VC3, Kanaway Tekakosawin, Being Cared For, was launched and utilizes technology to connect physicians and care providers and peers virtually in a COVID-19 era.
Regina Urban Hub was launched and scaled up peer advocates to include HIV and Hep C, diabetes, pregnant and nursing mothers, elders, and the opioid stewardship program patients. The results expected are peer training, program development on reserve and in the Urban Hub, and output of resources including training modules and manuals. The network expanded and food security identified. Future directions include long-term sustainability and scale-up. How can we better support people living with HIV or Hep C and or are using substances? Harmonize Indigenous and Western ways of healing within a peer network. This means the integration of harm reduction strategies, access to traditional cultural protocols and practice, and advocacy from people with lived experiences embedded into the current models of care. The peer network approach is adaptable to all forms of chronic illness prevention and mitigation.
The peer network originated from an annual team meeting with our partner communities in the CIHR grant, enhancing and expanding the Know Your Status initiative in on-reserve Indigenous communities in Saskatchewan. It is within this grant awarded to the Wellness Wheel team and partner communities that we have been able to reallocate funds to support the network. Some of our partners already have peers doing work in community and others are beginning a recruitment process.
Each partner community has the opportunity to select their own peer health advocates, ensuring that these peers are best suited to fulfill the needs and health priorities of their community. Community-specific peer programs address their unique needs, and FON will support each community in reimbursement for peers and further development of the program. The KD practice guidelines in peer health navigation for people living with HIV has been significant in providing general guidelines for peer program development. Peers have been recruited to the network, possess similar lived experiences to individuals who are unable to access care in the current Western healthcare system. Reflective of Know Your Status, we suggested that peers have lived experience with positive HIV or Hep C diagnosis or substance use. Ultimately, the determination is given to the community leaders. They will decide who has the most impact on their population.
The Virtual Community Care Clinic, VC3, Kanaway Tekakosawin, Being Cared For, was launched and utilizes technology to connect physicians, care providers, and peers virtually in a COVID-19 era. In collaboration with the University of Regina, mobile phones and data plans are provided to peers and communities for their outreach work. The mobile phones will be loaded with the VC3 software that allows for safe and confidential transfer of health information. Peer health advocates will have access to training on how to use the mobile phones and use the virtual environment software.
Peers serve as a connection to healthcare for people who may be newly diagnosed, engaged in care, withdrawn, or unable to access care. They help others to navigate the healthcare system, often meeting their clients where they are to facilitate access to services. This is different from care modules that will meet clients halfway. For some, halfway is not obtainable. We believe peers have the capacity to become ideal personnel to provide testing and treatment for individuals who otherwise would not access care. Mobile technology and HIPAA-compliant video conferencing apps would become a novel way of bringing physicians and care providers face to face with the hardest to reach individuals.
Fawn will develop a toolkit to include culturally responsive practices to guide peers. This will be a peer training manual that will include a variety of topics such as tips for confidentiality, boundaries, and harm reduction training. Development of operational materials to help communities support their peer program are ongoing and can be made at the request of communities. Fawn will encourage peers to use traditional protocols to support all aspects of wellness and culturally appropriate care. Pan-community training for peers hosted by Fawn or linked with other established peer networks across the province will give peers the opportunity to receive training in HIV and hepatitis C prevention and treatment, education on sexually transmitted infections, self-care training, and substance use basics such as identifying potential overdose and how to administer naloxone.
Peers are valuable as they provide practical assistance. They help in understanding barriers such as transportation, housing, childcare, and food security issues. They help clients with appointment reminders and the coordination and support clients before, during, and after appointments. Peers also assist with access to harm reduction supplies. Peers provide healthcare support when they update the healthcare team about what is happening in the community and by advising healthcare providers on what culturally appropriate care for clients. Peers provide education by relaying general HIV and Hep C knowledge, information about HIV and Hep C medication, information on holistic health, and education on harm reduction supply practices. They are also able to promote health and education events via connections within the community.
With our Wellness Wheel research team being based out of Regina, we have been grounded and experienced limited connection with our partner communities. Communities have shut down to avert COVID-19 from entering their communities. We do not want to risk the transmission of COVID-19. A partnership with Wellness Pharmacy on 11th Avenue has given us an urban hub to base peers out of. Some services available at Wellness Pharmacy include methadone services program, naloxone kit distribution and training, and a certified diabetes educator. Within our urban community, peers of various groups have been identified and refer to themselves as wellness warriors. These include elder support, formerly Regina COVID response team, a mama pod for pregnant and nursing mothers, and a diabetes pod. Food sovereignty and security is an important determinant of health and is an essential part of chronic illness prevention and maintaining a healthy living. Methods of food security have been integrated into the elder support, mama pod, and diabetes pod. Peers learn to grow and harvest food and medicines in outdoor gardens or in indoor hydroponic tower gardens, and they learn techniques of food dehydration, canning, and preserving in preparation for the winter months. Wellness Wheel has received funding for 5 tower gardens that have been placed in various locations with our partnerships, both in community and in urban settings, with the goal of them being completely managed by peers.
The opioid stewardship program at the Regina General Hospital has begun focusing efforts on working with people with addictions who are in hospital for infections and receiving acute care. The program has reached out to Fawn to help start peer support for these individuals while they are in hospital. The purpose of having peer support in the acute hospital care setting is to build a network for patients while they are in the hospital and to help them resolve their barriers while they're still in the hospital, such as housing, getting on social assistance, and if necessary, the Saskatchewan Assured Income for Disability program, so they are better set up after they leave the hospital. Support is essential during the time as the patient leaves the hospital. It could give them an opportunity to leave a situation or environment that is not ideal for recovery. Support could give them the opportunity to make a decision to seek counselors or for further treatment. If it never happens, the peer support gives them a chance and provides an opportunity that the patient may never receive anywhere else. We are in the process of recruiting peers for this support work at the hospital.
This is a diagram of our peer network organizational structure. There are many opportunities for feedback loops from all levels, as we are informed by our practices. The project coordinator oversees the various components of FAWN and envisions the direction of the network. The logistics and peer support person works with the individual peers, supporting their day-to-day activities. The peer coordinator guides peers through the hiring process and works closely with the peer consultant to ensure operational documents such as timesheets, activity report forms, and expense forms are all practical for peers to do their jobs. Our peer consultant, Danita, is an active peer mentor and activist and supports clients in the acute hospital care setting. To conclude, peers are integral to overall community wellness as they possess knowledge, expertise, and the ability to connect with community members and bring forth cultural responsiveness for care providers. FAWN's goal is for peers to be well supported to assist prevention, testing, care, and treatment delivery in collaboration with physicians and nurses to deliver a holistic, culturally directed care model. FAWN would like to explore the utilization of mobile technology to support peers and community workers to enhance linkage to care and treatment outside a standard clinic setting.
We would like to acknowledge our peers, community health center staff, community leaders, patients, elders, funders, and partners. Thank you.
To learn more about FAWN and Wellness Warriors, please visit our page on the wellnesswheel.ca website or email us at trisha.campbell@wellnesswheel.ca or danita@wellnesswheel.ca. Thank you.
Thank you for that very informative presentation. It's very important work that you guys are doing, so I really appreciate that. So with that said, we will continue with questions and comments in the chat. So it's been a very informative hour. Everyone's presentations were so amazing. So thank you all for participating and for being here today.